Good evening, everyone. Welcome to the IPNA Endorsed Webmaster Series 2020. We have a few technical issues, so we are not able to connect with the first speaker. He'll be coming shortly as a second speaker. So we'll take up the second talk as our first session. I'm happy to invite Dr. Uma Ali. She's currently a consultant pediatric nephrologist at Leelavati Hospital and Research Center, Mumbai, SRCC and Children's Hospital, and she's a head of nephrology there, and Jupiter Hospital, Thane, and she's a founder of Kidney Foundation for Children, and her major achievements being she's a former dean BJ Wadia Hospital for Children. She's a former head of pediatric nephrology and PICU Badia Hospital for Children, and she is the person who has established the acute and chronic dialysis services at BJWHC and pediatric transplant services at Leelavati Hospital. She's a former counselor of International Pediatric Nephrology Association and Asian Pediatric Nephrology Association. She's been awarded as 8 oration, including the prestigious PM Udani oration, and she has a Lifetime Achievement Award by IAP Pediatric Critical Care Chapter, and she has got a lot of national and international publications. Over to Dr. Umali.
Thank you so much, Kalaivani, for the introduction. And thank you and your organizing team for inviting me here. And so without wasting much time, I think I'll go on to my presentation. So is it visible?
Yeah, it's visible, ma'am.
Yes. Okay. Yeah.
Ma'am, are you there?
Yeah, I'm there. Yeah, I'm just figuring out. Yeah. Just one clarification. How do I move the next slide? I don't see that arrow. So that's why I want a little.
You can just put your enter button, ma'am, page down and up.
Okay, great. Thank you.
That's fine with us. Yeah.
Okay. Okay. So as we all know that the prevalence of AKI varies widely in different ICUs based on the kind of patients drained by the ICU, the complexity and advanced care which the ICU gives, and also by the different criteria that used to be used for diagnosing AKI, which has now become more uniform. So the prevalence varies somewhere from 8 to 20% in general PICUs, about 50% if you look at septic shock, and if you look at mechanically ventilated children with more than one inotrope, it might go as much as 80%. About somewhere between 1 to 5% of these children with AKI will need renal replacement therapy. Now, the advances in the modalities and the type of instruments available have increased and keep increasing with different options for modalities and different kinds of dialyzers. However, the studies and the understanding of the advantages in clinical outcome terms have not kept in pace. So we have a wide variety of modalities to choose from. And so we'll proceed to see how do we choose these modalities. Yeah. So our choice of modality is based on 3 aspects. One is the physiology, second is the evidence, and third is by pragmatism. Now, when we see physiology, what we are looking at is physiology of the fluids and solutes, physiology of the patient, and physiology of the modalities. Now, when we look at the physiology of the fluids, we are looking at the nature of the solutes to be removed. So the size of the solutes may determine whether we want to remove it by diffusion, if it's a small solute, by convection, if it is a middle molecular size solute, And we may even look at adsorption if they are large solutes, or use of high cutoff membranes if they are large solutes we want to remove. We also look at the rapidity of removal needed. Like if you're dealing with toxins, you may want to remove it as rapidly as possible. Whereas solutes like urea, you would probably want to remove it much more slower to avoid dialysis disequilibrium. And we also look at the rebound effect of where are these solutes distributed, because many solutes are distributed beyond the intravascular compartment, and hence they are likely to come back to the vascular compartment after removal. And so this may require more prolonged treatment to remove the ones which are coming back, or repeated treatments. In terms of fluid, we look at the rapidity of the removal needed, like if it's in pulmonary edema, you want to remove rapidly, but it may not be a very large amount you want to remove because the lungs can drown in a small volume of fluid. You may be looking at continuous removal if there's fluid overload with sepsis, ARDS, cardiac surgery to keep as dry as possible. And you're also looking at the volume of removal needed so that you can decide what modality you need to use. The patient physiology that we are looking at the age of the patient, hemodynamic stability of the patient, coagulation abnormalities, abdominal disease, respiratory status, vascular access feasibilities, and also raised intracranial pressures. Now, if we see what are the kinds of removals that are there, we are trying to mimic physiology of the kidney, and kidney removes most of the solutes, which non-specifically by convection. So we all know 120 ml per minute is the convective flow in the kidney, and the modality which most closely mimics it is convection. Okay. So convection by CVVH. So we know that CRRT itself has different varieties, and the hemofiltration mode, which you put as CVVH, H standing for hemofiltration, is the one where solutes are removed exclusively by convection. That means the solutes are dragged along with the fluid removal. So the greater the fluid we remove, the greater will be the solute clearance. And for removing greater amount of fluid, a greater amount of fluid has to be replaced so you don't get volume depleted. So the replacement fluid, the volume which we are giving per minute or per hour, is going to determine how much solutes you will be removing, assuming that you've chosen a membrane suitable for the solutes you want to remove. Diffusion is a method which exists in the body but not in the kidney for solute removal. And most of your modalities, PD, HD, SLED, and your CRRT, which uses just hemodialysis, they all use diffusion. They're using a concentration gradient to move solutes from higher concentration to lower concentration and thus purify the blood. And there are few modalities which combine diffusion and convection. So you have in CRRT, you have a CVV HDF, which has both hemodialysis and hemofiltration. And when you're using SLED, you can add a filtration component to it, and you can do what is known as SLED-F or SLED diafiltration, where the replacement fluid is generated by the dialysis machine, and so you can have a convective flow as well. Now, when we come to the different modes, the PD we know is good for children because there's a large peritoneal surface area in relation to body surface area in children. That is 522 centimeters square per kg in infant versus 285 centimeters square per kg in adults. The kidney receives 10% of the cardiac output. The peritoneum receives 10% of the cardiac output versus kidneys which receive 25%. The mesenteric blood flow is about 50 to 100 ml per minute, which is the kind of blood flow you're looking out for infants and smaller children. Disadvantage, we all know fluid removal cannot be set, but can be manipulated. Abdominal distension can cause respiratory embarrassment, and it's contraindicated in unexplained abdominal disease or recent abdominal surgery. When we look at CRRT, our requirements are CRRT is not one modality. When it is a broad umbrella term under which we have three modalities. We have a continuous hemodialysis, hemofiltration, and a hemodiafiltration, as we discussed earlier. What it requires is a dedicated machine, so one would have to invest in that. Trained nurses. It has high resource utilization because you need a nurse to patient ratio of 1:1. In our setup, it's also costly. You have to be very careful about filter clotting because that kind of hampers your full procedure. And close monitoring and titration to prevent hemodynamic instability, dyselectrolytemia, and filter clotting. There are also, what we don't realize is nutritional issues which come up because when you're doing it continuously, you're not removing only the unwanted solutes, you're also removing a lot of amino acids and nutritional components, which we are not measuring. And hence, a good nutritional plan has to be there along with this. When we come to SLED, which has increasingly become one of the more widely used methodologies in PICU in India, you need a RO plant for supplying the pure water. You need machines that can deliver low dialysate flows. The dialysate flow rate to blood flow rate has to be much lower than what we use for hemodialysis in order to make it truly slow efficiency. The S stands for a slow efficiency. So it has to be less than 2:1. Now, conventional dialysis machines, which hospitals have, can give you only a dialysate flow rate of 300 ml per minute. So it can really be used for SLED only in children weighing 30 kgs or more.
You're not connected to my desktop.
Yeah.
Okay. And then you didn't download anything from my computer?
Yeah. So you have certain dedicated machines. You have a Fresenius Art Plus, which can give you a dialysate flow rate of 200 ml. So it can be used for children weighing 20 kg or more. For children who are lesser than that, the Fresenius 5008 gives you a dialysate flow rate of 100 ml per minute. So it can be used for 10 kg or even smaller with minimum blood flow rate of 50 ml. However, the company recommends not to use it below 17 kg as the accuracy of ultrafiltration rate at that weight cannot be assured. We also have a Nipro NCU 18, which gives a dialysate flow rate of 100 ml per minute. We haven't received any specifications from the company about whether we can really accurately use it for smaller children continuously. So SLED, if we want to add a convective mode, like we're treating a child with sepsis and we want to remove a lot of middle molecules, then we need to add the replacement fluid. And since the replacement fluid is generated by the machine, you have to have ultra pure water, and your water, RO water, has to meet the standards of ultra pure water. jumping. Have you just...
You're able to move your slides, ma'am?
Not very comfortably. Okay. So there are, now what happens in an Indian scenario? No, I think it's jumping. 1 second. Yeah, this is fine. If you have a child less than 15 kg and you do not have a dedicated machine for providing SLED and you need to give a prolonged therapy, then the only extracorporeal therapy you have is actually hemodialysis. Now, in order to make this hemodialysis safe for a hemodynamic unstable child who's maybe less than 10 kg, you can keep the blood flow rate low at 5 ml per kg per minute. Keep the dialysate flow rate at the lowest that the machine can give, and give low ultrafiltration rates like we would with CRRT or SLED, and give a duration like SLED for 6 to 12 hours. The difference between this and SLED, why it does not qualify as SLED, is because the dialysis flow rate to the blood flow rate is more than 2:1. But although this has not, the solute clearance has not been formally tested, it's likely to be not a very efficient removal, which is what we are looking at. Since at such low blood flow rates, the clearance is determined by the blood flow, and increasing the dialysate flow rate will not be greatly impacting the clearance. So when blood flows are very low, below 100 ml per minute, then by increasing the dialysate flow, the clearance does not increase. So we have published experience on this in Hemodialysis International this year. So when comparing the major differences between the three modalities, hemodialysis, SLED, and CRRT, hemodialysis you can use with your conventional machine. SLED with a conventional machine only if it's over 20 kg. If it's lesser, you need the dedicated SLED machines. CRRT needs its own machine. Need of dedicated RO is if you need HD or SLED, you don't need an RO for CRRT. In hemodialysis, you're essentially using low flux dialyzer. In SLED, you can use usually a low flux, but if you're doing SLED F, you need a high flux filter. High flux filters are not available here for smaller sized children. So essentially it's for children above 15 to 17 kilos that you can use a hemodiafiltration on SLED. In CRRT, of course, you're using a hemofilter. In hemodialysis, we're using a pure diffusive mode. In SLED, but if you do SLED F, you are adding a convective mode to that diffusion. And in CRRT, you get to choose. You get to choose whether on a diffusive mode, convective mode, or both. Cost is low for HD, low to moderate for SLED, and quite high for CRRT in our setup. The technical difference are the blood flows are not very different. You keep around 5 ml per kg for both. You could go up a little if you need. Dialysate flow is what is making the difference. It's 500 ml per minute in hemodialysis, 100 to 200 in SLED, and in CRRT it comes to hardly 35 to 40 ml per minute. You can do anticoagulation free quite easily with hemodialysis and SLED. You can do it in CRRT, but you have a high risk of filter clotting. So usually heparin citrate are used, and I think Akash will discuss that in detail. Hemodynamic stability, we all know, is poor in hemodialysis. It's good in SLED, it's good in CRRT. The net hourly fluid removal is often high in hemodialysis because you're doing it only for 4 hours. Whereas in SLED, it may be 2 to 4 ml per kg per hour, and in CRRT, it would be 1 to 2 ml per kg per hour. So we go next to see what is the evidence we have. We've understood physiology. Do we have evidence that one modality is better than the other? Okay. Now, I've just chosen, there have been many meta-analyses. I've chosen 3 in the last, in this decay. 2013, 17, 20, this is adult systematic reviews and meta-analysis. And each of them had a large number of studies, 23, 18, and 22, and a large number of patients. They've looked at different aspects, but the ones which have looked at renal recovery shows there was no difference in renal recovery between CRRT versus SLED, or CRRT versus SLED hemodialysis, or not completely described prolonged intermediate renal replacement therapy. Neither was there in the study. One study looked at it, time to recovery. There was no significant difference. One study looked at dialysis dependence after ICU discharge, and they found that it was more with the intermittent renal replacements therapies. But this difference was not obvious. It was more when you looked only at observational studies. But when you looked at RCTs, the difference was not so obvious. Mortality was not significantly different in one of these studies, but in two studies, the mortality in 2017 meta-analysis by Kovac et al. Showed it was lower with SLED. Again, when they adjusted with the RCTs, they found that the mortality was not different. In the 2020 by Zhao, the meta-analysis showed that when you compare CRRT with hemodialysis in adults in ICU, the CRRT had a higher mortality. Now, these studies don't have, although they've looked at the severity of illness, this may have been because of the various choices made that the hemodialysis ones were given to adults with lesser instability. There's been also meta-analysis which look at PD versus extracorporeal therapies in adults, and no difference in recovery of renal function, no difference in correction of acidosis, and in infectious complications or in mortality. But the extracorporeal therapies, whether it was hemodialysis or CRRT, were better at both solute and fluid removal, but it did not translate into better clinical outcomes. There was one interesting study which looked at something which we all worry about. Does SLED cause more hemodynamic instability than CRRT? So this is RCT done in India, and two groups, and one receiving CRRT and SLED, and these were in patients with sepsis and septic shock. And they had quantified vasopressor index, vasopressor dependency, and what they found was there was no hemodynamic difference whether you use CRRT or SLED, but there was a definite solute clearance which was better with CRRT. There have been not many pediatric studies from India, so I've just compared the recent ones published. And what we do find is the UK, US one are large studies looking out over many years. Sorry. And what has been seen in all, of course, the utility is different, whereas the Indian studies, sorry, I think it's just, was a small single center study, but since it was a recently published one, I've used it to just give an idea. Mainly use PD or HD, with PD as the predominant mode. And the mortality with PD was much lesser than the mortality with HD. But however, if you look in detail in the article, most of the deaths in HD occurred during or soon after the HD. And so it raises a question that of whether the technique was well followed and the expertise of using hemodialysis in critically ill children was good enough. The UK and US studies, the UK has no, very little hemodialysis. They're all CRRT or PD. US has a CRRT followed by PD and HD, and then PD as the prevalent modes. And what they also found was that the PD has the best outcome and the least mortality. Again, these being observational studies, it could mean that PD was used for lesser sick children who are less sick compared to CRRT, which was usually used in sicker children. So that since the choices are not so clear, it cannot kind of be translated into a modality superiority, but it may just mean that chosen rightly, PD is a good modality. So we come that since we do not have clear-cut evidence to say that one modality is better than the other, we take a pragmatic approach, and we decide based on the limitation of the modalities, the age of the child, the available resources, optimal resource utilization, available expertise, and the technical support which we can get, and the cost of the technique. Okay. So I'll briefly run through a few cases. This was, since we're running short of time, I'll just give you a brief summary. This was a child who underwent a post-operative repair for truncus arteriosus and had a post-op creatinine of 0.8 with a low urine output, was on 3 vasoactive drugs, and was given IV Lasix. Urine output increased, but the creatinine also went up, and the sodium went up, potassium went up, bicarb dropped. So definitely this child was in need of dialysis. And our choices now come to what do we do for this child. So we want to treat the hyperkalemia, normalize sodium, correct acidosis, reduce fluid overload. And our options are, obviously we are not going to be using, we have a lot of hemodynamic challenges, which are obvious that this is a small child at risk for both fluid overload and poor cardiac output. And so obviously we cannot use intermittent hemodialysis. We can't use SLED at this age and size. So we have an option between PD and CRRT. And in our center, most of these children come with a PD catheter in place in case it's needed. So PD is the modality of choice. And this is the UK data where 81% of post-cardiac surgery actually get PD as their modality of choice. This is a 10-day-old baby who was operated for bladder extrophy, developed post-op severe infection, went into shock, needing fluid bolus, dopamine, change of antibiotics to meropenem, became severely septic with anemia, fallen platelets, elevated liver functions, and prolonged PT-PTT, and he obviously needed dialysis because there was too much of metabolic derangements. PD not feasible, he was operated for bladder extrophy, HD not feasible because of age, and SLED not feasible because of weight, as well as the need for a continuous modality because there was so much derangement and he was anuric. So CRRT was the only option. We all know that as yet, we do not have commercially available dedicated devices for newborns, which will give low extra corporeal volume and UF precision. There are dedicated devices which have been developed and used in centers. And we know there's Carpedium, which is a cardiorenal pediatric dialysis emergency machine, which has an extracorporeal volume of just 15 ml and an accuracy of ultrafiltration of 7.5%. You have the NIDIS, the Newcastle dialysis system, which has an extracorporeal volume of 10 ml and less than 0.25% precision of ultrafiltration. You also have people who have adapted devices. You have the Aquadex FlexFlow system, which was devised for just removing, as the name suggests, aqueresis fluid from adults with refractory cardiac failure. That has been adapted and tried for children because it has a small extracorporeal volume of 33 ml, but a little higher, less accurate ultrafiltration. But you can only do filtration in it because it does not have dialysis or countercurrent flow. But it is an alternative. And so here we have the carpedium on the left, the Newcastle Nidus picture, and the aqueduct system. Now, obviously, we don't have all that. So what we use for neonates is Prismaflex with HF20 filter. But this actually has an extracorporeal volume of 60 ml, which is 20 ml kg in a 3 kg child who's unstable. But the challenge is a vascular access in a coagulopathic volume overloaded child. And even getting the right catheter took us 5 hours. This was put femoral vein and the FFP platelet cover on adrenaline, noradrenaline, blood priming was given, and the worry was the already existing hyperkalemia. And we did the CRRT without anticoagulation. We didn't have major issues with the CRRT, but the child worsened with purpura fulminans. The blood culture grew carbapenem-resistant Acinetobacter, which was fairly uncommon in our ICU before that. So we added colistin, but the child continuously worsened and expired, despite the CRRT part functioning well and being able to achieve the fluid and other solute goals. I think this is a child, 11-year-old boy with acute myeloid leukemia, and his biochemistry suggests a tumor lysis syndrome. And we know to diagnose tumor lysis, you have to have 2 out of these 4 criteria positive within a 24 hours period, either 3 days before or 7 days after the chemo initiation. And he had 2 of this, a uric acid more than 8 and a calcium, which was less than 7. And the important thing is that high uric acid may cause microtubular obstruction and calcium phosphate precipitation in tubules. So the first line, if the kidney function is okay, is to give a high rate of fluids to flush out the solutes. A number of queries come, what we should do, alkalinization, diuretics, calcium, etc. The recommendations are pretty clear that you need to give fluids if the kidney function can excrete that much. In a low risk category, intermediate, you may use allopurinol. In high risk, rasburicase. Urine alkalinization is not recommended, and potassium should not be added, and asymptomatic hypocalcemia should not be treated. So this child, because he wasn't excreting what was being given, his creatinine was already little high, needed RRT. Amongst the various choices, what happens is many of these are easily removed by diffusion, uric acid, phosphorus. So diffusion mode like hemodialysis is good enough, but there is likely to be rebound effect. So if one is using hemodialysis, one has to use it repeatedly, maybe daily. Alternatively, one can use SLED to remove it for a little longer duration of action. So the choice depends on the unit. This is the last case, which is a 18-month-old with sepsis, myocardial dysfunction, AKI. He had undergone PD in another city and was on mechanical ventilation for repeated extubation failures. He developed peritonitis and tunnel infection. He was extubated over there, catheter was removed, a drain was left in C2, and he was transferred for further dialysis management to our unit. He weighed 8.5 kg, he was edematous, oliguria, his ejection fraction was less than 30%. He had extensive skin peeling over his entire abdomen and also over the site where his femoral access was there. And he had a low urine output, less than 1 ml, and he was hyperkalemic, acidotic, anemic, and he had a prolonged PT-PTT. So I think he definitely had all indications for dialysis: oliguric, hyperkalemic, acidotic, fluid overload. And he also had multiple comorbidities: infected abdomen, extensive skin excoriation, cardiac dysfunction. We did not have a dedicated SLED machine at that time with low dialysis flow rate. He also had vascular access issues because the left femoral site had a skin excoriation. His right femoral had his central line for fluids and inotropes. Right IJV, I presume they had tried there, already had a thrombus, so he only had this left IJV left. CRRT had cost issues because they had already spent a lot in the other hospitals, so they didn't have that much money. So we were a little concerned about how to give him the FFP platelets, blood, etc. for the access without removing some fluid. So what we did was we did a temporary dialysis through the abdominal drain which he had, with short dwell times just to reduce potassium and create some negative balance. So 10 ml per kg in, 10 minutes in and out. So over 6 to 8 hours, that became less, and we gave him FFP platelets, put in a left IJV catheter. And this is the child we first did the prolonged daily hemodialysis after blood priming with a blood flow of 50 ml, dialysate of 200 ml. So the ratio was 4:1. And we did not initially remove any fluid. We just got the solutes okay. And later on, cautious fluid removal to match intake. And he underwent 32 daily PDHD sessions. But with the tube feeding, antibiotics, antifungals, gradual healing of skin lesions, he no longer had a fluid overload and had a gradual improvement in urine output. And ultimately, a month later, was extubated and discharged with a partial renal recovery. His creatinine did not touch normal, although his urine output improved. The choice of modality, therefore, which we use to sum up, depends on age, underlying disorder, need for rapid solute removal, need for continuous fluid removal, infrastructure, facilities, local expertise, and cost, challenges faced by vascular access, abdominal disease, raised ICP, bleeding risk, size inappropriate circuits, which we all get in India. And so it may, and the need for continuous fluid removal. So roughly, if it is a neonate, one would go for PD or CRRT. Most of the times we get away with doing PD, but CRRT, if it's an inborn error of metabolism or abdominal disease. If there's raised ICP, you don't want to fluctuate the intracranial pressure, so CRRT would be your modality of choice. But in the absence of those facilities, whether 24-hour SLED would meet the requirement, needs to be studied. There is one small study in adults where there was a crossover between CRRT and SLED, where the uremic intracranial bleed and the pressure differences was not significantly different between the two. But that's only 9 adult patients. Similar issues apply when we have liver cell failure. Sepsis-associated AKI, probably we could use CRRT or SLED, which has been both used successfully. And sometimes even PD if abdominal issues are not a major issue. Hyperammonemia, CRRT would be a modality of choice. If it's an older child, even hemodialysis is good. And PD can bring down ammonia initially, but does not bring it at the same rate as you would get in CRRT. But if you have no other option, one can start off with PD and then transfer to a center which could do CRRT. So one last question, that why doesn't a modality that is based on sound physiology like CRRT or CVVH, which mimics glomerular filtration so well, does not translate into a better outcome? Some of it definitely is because you need sufficient expertise in its usage and your whole team needs to be trained, which sometimes may not happen adequately in India. A blurred interface between nephrology and intensive care. Nephrologists may not be that well versed with all that is happening in critical care, which moves at a much faster pace than nephrology. So the assessment of fluid adequacy, etc., very important issues in intensive care. Nephrologists sometimes run behind that and are not as well knowledge. And it goes the other way also, that not all intensivists are well versed with nephrology issues. They just look upon the machine as something to pull out fluid. We do not have any single parameter to judge intravascular fluid status in critically ill children. So most errors are made there. And very important, there's no parameter for assessing vascular refilling in a septic child, that, okay, you've removed from intravascular, is your fluid overload 20%? Is it coming 5% coming back to your vascular compartment to enable removal? So you have and also the studies may not be all very appropriate. Sometimes it's like comparing apples with oranges. And sometimes you feel the endpoints which we are looking at may not be the best endpoints. We do need to know outcome, but it's highly unlikely that just one intervention and one modality is going to change your outcome in terms of mortality if you're doing something else inappropriately. So unless everything else you're doing in the best possible way, your dialytic modality is not going to change your mortality unless you're using it inappropriately. So it could do things for the worse. So when we choose finally a modality, we have to answer these two questions. That will my team be able to use this modality for this patient without causing hypertension and hypovolemia? As intensivists, we take pride that we dealt with the hypotension very promptly and it got corrected. But every hypotensive episode is adding to the acute kidney injury and preventing its time of recovery and long-term recovery. So it's added injury, which we have to prevent rather than be happy we treated. Second, will I be able to use this without adding to the existing problems of causing iatrogenic injury? So I think these are the primary things which we need to address. And unless we address all these issues, we may not be able to deliver the modality which we have at hand as effectively as it should be delivered. Thank you.
Thank you so much, ma'am, for giving an exclusive talk and outlining on various modalities of ORT in PICU. Ma'am, can we take up the next talk by Dr. Deep? So it goes in flow.
Yeah, so we take up Dr. Akash Deeps.
Yeah, yes, ma'am. Like a CV is there.
Yeah. It's my pleasure to introduce Akash Deep, whom I've known for a long time. Most people here would be knowing him and I've heard him many times. He started off his journey in intensive care in India, where he was in the first batch of fellows who passed out in the critical care fellowship. And subsequently, his career has been in UK. And currently, he is director of the pediatric intensive care unit at King's College and a reader in the pediatric intensive care at King's College London, which is one, and the King's College is one of the
You're not audible, ma'am. Akash sir, we shall proceed with your talk. Is that fine?
Yeah, absolutely.
Like, I think madam's net is little down. We shall proceed with the talk, sir.
Okay.
Dr. Akash
Can you
Deep,
see
thank
the
you so
slides?
much. Yeah, I am able to see you.
Perfect. Thank you.
Yeah.
Okay, I'm gonna pull my slides up. Okay, great. First of all, thank you, Dr. Ganesan, for having me here. It's an absolute privilege and an honor to be on the same platform as Prasad and Dr. Umali. So after what Dr. Umali has told you all about the different machines, different modalities, we've talked about carpedium, we've talked about nidus, aqueducts. I think we can go on and talk about as much funkier modalities and machines as we can. But one thing which determines the successful running of your CRRT program is the longevity of the circuit. How long does your circuit last? Because that will determine your filter life, that will determine how can you slow down your downtimes and increase the efficacy of treatment. So what I'm going to do in the next half an hour is to take you through the anticoagulants in CRRT, which can help prolong the filter life. So if you look at various subspecialties of pediatric intensive care, we were on CAVH, and gradually as the decades have gone by, we have not only come to different modalities and different machines, we have also manufactured machines which are very dedicated to newborns, the carpediums, the nidus and everything. But as I said, the key element, despite this advancement, is the delivery of therapy. We need to make sure that what we prescribe is what we deliver, or at least as close to what we prescribe. So if you look at the different meta-analyses which have come out, the systematic reviews which have come out, anticoagulation-related factors are counted as one of the most important ones. Look at this systematic review, and you can see that out of the 8 quality indicators of CRRT, 4 of them are anticoagulation related. To choose the anticoagulant, how do you monitor anticoagulation? What are the complications? And what are the circuit related issues? So anticoagulation related factors to maintain the patency of the circuit, to help optimize your filter life, is very important. And if you look at this particular systematic review from Sean Bagshaw, where it was published in 2017, and there were about 18 quality indicators cited about 298 times, and you can again see that filter life features here as one of the most prominent one, and similarly bleeding secondary to anticoagulation features here about 30 times. So both which anticoagulant to choose and what are the complications and the safety issues. In other words, looking at safety and efficacy of the chosen anticoagulant is very important. So as I said, the circuit life, we can go on and on about what circuit life depends on. It depends upon your circuit factors, and it depends upon your other factors, which means your patient factors and your treatment factors. I'm going to concentrate on anticoagulation specifically in this talk. So the questions which we need to ask ourselves is, why do we change filters? Why do we change the circuits? And in other words, is everything what you change is due to a clotted filter? Why do circuits clot? I'm going to go through the various anticoagulants available, their actions, their advantages and the disadvantages, and try and answer the question based on evidence. And is there a single best anticoagulant? And then talk about anticoagulation in special circumstances, especially in liver and in COVID. So why do we change filters? Why do we change the circuits? Yes, a circuit might have clotted, but a number of times, if the circuit has gone on for 72 hours, it could be because of the manufacturer's recommendation that we are now changing the circuit. Very importantly, a thing which goes missed a lot of times is your access malfunction. There could be kinking, there could be bending, there could be a leakage around the vascular access, or there could be an inappropriately small size of the vas gap. It might be that your machine is malfunctioning, and a very practical issue, i.e., that your patient has gone down for a CT scanner, he's gone down for liver transplantation, and you've interrupted your CRRT, that is considered as a change of circuit. So in a sense, what I want to say is that every changed circuit, every changed filter is not secondary to a clotted circuit. Now, if you look at this paper from Dr. Bellomo, you can see that they looked at 140, 150 ICU patients, 428 episodes of CRRT, and about 500,000 minutes of CRRT, looking at blood flows, your access pressures, your effluent pressures, looking at the pre-filter pressure and return pressure. And then they divided their patients into 3 categories: early, intermediate, and late change of circuits. And they actually found it was the access dysfunction, which they defined as access pressure less than or equal to minus 200 millimeters of mercury. And they found that the circuits which clotted, they had a higher incidence of access malfunction as compared to circuits which were electively changed. And when they entered everything into a multivariate analysis, again, the first access dysfunction event was significantly associated with a circuit failure in the next 24 hours. So it is said that a well-functioning large bore vascular access put in the appropriate position is the best anticoagulant, and that's what we practice. And again, we can talk about where do you cite it. We cite it in the right internal jugular vein, because the right atrium is the largest reservoir of blood, and you get the least amount of recirculation there. Now, this was a work done from our team at King's, where we looked at factors affecting circuit life during CRRT in liver failure. And what we found here is what I have said, that every changed circuit was not because of the clot. It was only 25% of our circuits were changed because of the clotted filter. There were many other reasons, as you can see here, whether it was a VASCAP blockage, it was a circuit problems. There were other reasons why we changed the filters. And very importantly, if you look at here, that there were circuits which were changed 2 hours before we had given the blood products. Your VASCAT blocked within 2 hours of giving more platelets and FFP, and your circuits clotted after giving cryoprecipitate and your FFP. So sometimes what people do is when they're giving the blood products, they temporarily go up on their anticoagulation. It's not a practice in our unit, but there are certain units which practice that. So be mindful that when you're giving patients platelets or cryo or FFP, and sometimes there is no access and you have to give it post-filter, there might be a chance that your circuit might get clotted. So why are we worried? The question is, yes, you're changing the filter, so why are we worried? And the biggest answer, or the most important answer is the downtime of treatment. Because the downtime for treatment which determines the efficacy of your treatment. So more filter clotting, more downtime, and it will be increased blood loss, especially in newborns. And very importantly, when you are changing the circuit, you can get hemodynamic instability. And of course, ask your nursing staff, they would want to kill you for changing the circuits again and again. So make sure that your circuits run appropriately. And this is, I would say, the single most important thing, what you should ask your nursing staff on ward rounds. Are there any access issues? What are the access pressures? And how many times has the filter been changed in the last 24, 48 hours? So this is one of the graphs we took from our patient with acute liver failure. You can see the transmembrane pressure is nice and stable, and your ICP is nice and stable. As your transmembrane pressure starts to go up, look, your ICP is going as well. And as the filter clots, your ICP goes up further. So what I'm trying to say is that in certain etiologies like acute liver failure, which is very, very sensitive to ammonias, and you need to bring the ammonias down, decreasing the filter surface area by clogging or clotting is not going to serve good to your patient. So this is what happened to this patient who had acute liver failure where circuit was clotting. So what are the factors related to premature clotting? It could be patient-related, access, circuit, or treatment-related. And I'm going to go very quickly through this paper by Warwick Butt from Australia. It was just published last month, where about 22,000 hours of continuous kidney replacement therapy was studied, median duration of 74 hours. Of the 572 circuits which they were used, about 50% of them were circuit clot. This is actually quite a higher number of circuit clots as compared to the conventional data, which has shown about 25 to 30%. And what they found was that of the patient and treatment-related factor, it's admission, diagnosis, anticoagulation type, access, and circuit size, which mattered. And this is what I wanted to concentrate on here. Look at the different diagnoses. You've got diagnosis from cardiac to sepsis. And if you look at the liver one, the circuit life is literally less than 10 hours. And this worries me. I had actually written a letter to the editor saying that a circuit life of less than 8 to 10 hours in a patient with liver disease is worrying, because you're changing the circuit so often, the ammonias are going to go high. And if you look at the paper, they have cited that the mortality in this particular group is higher as well. So your circuit life will depend on the patient characteristics. For example, for sepsis, you might have decreased antithrombin, which might have, again, a secondary effect on which anticoagulant to use and how to use it. So where does the thrombus form? Anywhere where there is stagnation, wherever there is a turbulent blood flow, you will find that thrombus might form. For example, here where there's a bubble trap, you've got a vascular access and the hemofilter. These are the three most common places where the thrombus will form. And in the bubble trap, there is stagnant flow, there's a turbulent inflow, plus there's an interface of the blood with the air. So all things leading to more propensity for the circuit to clot. And of course, we are using smaller vascats and lower blood flows, which are adding problems as well. Right, before we go on to anticoagulation, as I said, non-anticoagulant measures, large catheters, higher blood flows, using of large pre-dilution rates, and when you're using the CVVHD mode, make sure your filtration fractions are less than 10%. So these are the non-anticoagulant measures to increase your filter life. Now, Patrick Brophy from the PPCRRT registry in the early 2000s has shown us from the 7 PPCRRT centers, they had 138 patients, 442 circuits, and 18,000 hours of CRRT. 52% of their patients used heparin, 36% of them used citrate, and 12% of them had not used any anticoagulation. And if you look at their data, you see that there was no difference in the circuit life between heparin and citrate. But if you compare it with no anticoagulation, you definitely find that the filter life was much lower in those patients where no anticoagulation was used. And if you look at the log-ranked analysis, there were 69% of the circuits which were anticoagulated with heparin and citrate, which were functional at 60 hours, as compared to only 28% when no anticoagulation was used. So therefore, papers like this have shown that anticoagulation goes a long way in prolonging your circuit life. Now, what is an ideal anticoagulation? How do I choose one? A, it should be readily available. B, it has to be safe. When I say safe, I mean it has to be selectively active within the circuit with minimal effects on your patient hemostasis. It ideally should prolong your filter life by more than 48 hours. The monitoring has to be rapid, simple, and in case you do develop complications, there should be an antidote available, for example, protamine for heparin. And very, very important, the people who are running your shop floor, your nursing staff and your junior doctors, they should be able to follow a protocol which is simple, which is uncomplicated, and there has to be staff training. So this is an exhaustive list, but what I'm going to do is to just concentrate on these 4: heparin, low molecular weight heparin, citrate, and prostacyclin. Now, before we go and talk about different anticoagulations, we're going to go back to med school and just have a peep at what is the clotting cascade. Clotting takes place when there is an interaction between different components of your clotting system and platelets with the endothelium. This is the classic intrinsic and the extrinsic clotting pathways, where you see that at different steps you've got calciums and platelets. So calcium, platelets, and different components of your clotting system make up your clotting cascade. But I think things have moved on. Instead of talking about intrinsic and the extrinsic pathways, what nowadays we talk about is thrombin generation. Everything revolves around thrombin. Thrombin upregulates its own production, and thrombin can down-regulate its own secretion as well. When it binds with thrombomodulin and protein C and protein S are activated, you will see that actually thrombin is able to down-regulate itself. So everything depends upon thrombin generation, whether it's what's up-regulating or whether it is down-regulating. So heparin, most commonly used anticoagulant. People have large experience in using it. It has got a short biological half-life, and very importantly, you've got the availability of an efficient inhibitor in the form of protamine. If you have to neutralize 100 units of heparin given pre-filter, you have to give 1 milligram of protamine post-filter, but you have to remember that it also depends upon when do you start your heparin. If you've started your heparin like less than 30 minutes and complications develop, it's 1 milligram per 100 units, and if it is between half an hour to 2 hours, you can even get away with 0.5 to 0.75 milligrams of protamine for every 100 units of heparin. Now, again, how does heparin act? Heparin inhibits two major clotting factors, factor 2 and factor 10. Factor 10 is a small molecule, whereas factor 2, which is thrombin, is a large molecule. And this is my favorite slide of everything. You can see here that this is thrombin. It's a large molecule. You require a larger chain, and this is the unfractionated heparin, which is made up of repeating sequences of pentasaccharide sugars from 5 to 100. So you can see that a large molecule, a large chain is able to antagonize thrombin. But if you have to have low molecular weight heparin, it will not be able to antagonize thrombin, whereas it will easily be able to antagonize factor 10. And that is the way you monitor the effects of heparin. If you're using low molecular weight heparin, you use anti-10A, whereas if you're using unfractionated heparin, because it has got a large chain and that large chain can neutralize both thrombin and factor 10, you will see in my further slides that actually you can use both ACT as well as anti-10A to monitor the effects of your therapy. And this is the anti-10A guided anticoagulation therapy from Evelina. This is Andrew Derwood's slide, which who very kindly lent it to me. They target anti-10A levels between 0.4 and 1. Then accordingly, they kind of regulate the heparin therapy. But we have to remember that not every day, you can't get the levels of anti-10A very quickly. So that things need to be borne in mind. And what is the protocol? Some units use a bolus dose of 10 to 20 units per kilo. We don't use that. We infuse heparin at 10 to 20 units per kilo per hour, and we maintain a post-filter ACT between 180 to 200 seconds. And the personal practice is that we actually start off with 20 units per kilo per hour. What are the side effects? Bleeding is the most common side effect, followed by heparin-induced thrombocytopenia. So this is the paper, the same Warwick-Butts paper, where they have shown that the efficacy of the filter life depended on the heparin dose, and it depended upon how high they were able to achieve the APTT. So both heparin dose and the ability to maintain your ACT or APTT determine the filter life in this particular paper. Now, as I said, there are certain side effects to heparin in the form of bleeding, in the form of unpredictable pharmacokinetics, which low molecular weight heparins like dalteparin, enoxaparin, and natriparin can be useful for. Having a small molecule, you will have more anti-10A activity with the low molecular weight heparins. There will be more predictable pharmacokinetics and hence more reliable anticoagulant response, but there is no quick antidote. If things go wrong, you might not be able to reverse the bleeding as you might be able to do using protamine in unfractionated heparin. The cost is higher, and very importantly, there is no difference in filter life. So to summarize heparin, I would say it's most commonly used, it's easy to use and monitor. There are systemic side effects which are significant, and it's contraindicated in a bleeding patient. Now, when there are so many complications and so many contraindications, I would say to heparin, investigators started looking around and saying, what is an alternative? And then if you look back at the cascade which I showed, you saw that calcium at every point was involved in the intrinsic, extrinsic, or the common pathway. So if we were able to neutralize this calcium within the circuit, you might be able to achieve anticoagulation. And that's what the action of citrate is, where it acts with the ionic calcium within your circuit, and it decreases the ionic calcium. Therefore, calcium is not available for your for the escalation of your pathways, and it acts as an anticoagulation. And this is how it is delivered. Your citrate is delivered pre-filter, and it is 1.5 times your blood flow rate. If your blood flow rate is 50, for example, your citrate will be 75 mils. And then because it can cause hypocalcemia, you actually replenish your calcium either via a different central line, or you have a third lumen of your dialysis catheter where you can give your ionized calcium. So we measure it after 2 hours of starting the citrate, and then we measure every 6 hours. And the aim is to maintain your systemic ionized calcium between 0.3 and 0.4, and patient's ionized calcium between 1.1 to 1.3. So what are the advantages? I think the single most advantage I would say is A, it prolongs filter life. I'll show you more than heparin. B, it has got almost zero effect on patients' bleeding. And bedside surveys have shown that there is less work of machinery, therefore allowing more attention to patient details. What are the problems? There are lots of metabolic problems. As I said, because citrate gets metabolized in the liver, you can get alkalosis or acidosis, you can get hypernatremias, and you can get alkalosis or acidosis. And this is the kind of how do you titrate your citrate infusion based on the citrate sliding scale. If your ionized calcium is less than 0.35, what do you do? If your ionized calcium is more than 0.6, what do you do? I'm very happy to share these slides later, but these are intricate details of what to do if your ionized calcium gets lower or higher. And what is considered as a major complication is citrate lock. As I said, 50% of your citrate which you're giving get bound to ionized calcium within the circuit, but the remaining 50% gets delivered to the patient, goes to the liver, gets metabolized in the liver. But if your liver is not functioning, or due to any other reason, if your delivery of citrate exceeds the ability of your liver to metabolize citrate, your problems will start. Your ionized calcium will start falling, and your citrate bound and your protein bound calcium will start rising. And that is where you call a citrate lock, where your ratio of total to ionic calcium, if it exceeds more than 2.5, both at initiation and at 3 days of CRRT, it actually predicts increased mortality. What do you do in such a case? Either you stop citrate for 3 to 4 hours and decrease the rate and start at 70%, or you increase your dialysis fraction to enhance your clearance. So you need a well-designed and a flexible protocol. It needs to be adjusted to the local preferences of modality and dose, and make sure you have got the facility to monitor your ionized calcium 24/7, because you need to make sure that A, your ionized calcium within the circuit, and B, your ionized calcium within the patient is okay. But very importantly, you need to train your staff. At King's, we have never used citrate. We are a prostacyclin using this thing, but we are not very familiar with the use of citrate. Now, if you compare citrate versus heparin, and these are the 5 RCTs, they have shown that 3 of them have prolonged filter half-lives, and 4 of them have shown that there is less bleeding with citrate as compared to heparin. And they have shown that there is more transfusion requirements with heparin as compared to citrate. So this is a study which was done in children which were less than 10 kilos, and this study has shown that not only is the filtered life more in citrate as compared to heparin, it was safe and easy to be used as well, and there was a better 28-day hospital survival using citrate as compared to heparin. Now, this was a study from the IPNA group, our nursing IPNA group of critical care nephrology, published this paper about a couple of years back in pediatric nephrology, where they compared heparin with citrate. You can see that almost the number of hours are the same, and you can see that both adjusting for elective and non-elective, you can see that the filter life with citrate is much better than with heparin. And if you look at what they prescribed and what the patient actually got the dose-wise, it was 85% of the prescribed dose was delivered with heparin and 92% was delivered with citrate, and it was safe as well. So therefore, this group actually prove that it's safe, it's efficacious, and your prescribed and the delivered dose can be quite close to each other. This was a paper from Czechoslovakia by Thomas Zoral, where he did a very elegant piece of work and said, I'm gonna alternate the circuits. So what he did was he gives CVVHDF to his patients, and he used heparin citrate in this consequence and in this sequence, and he looked at the filter half-life. And when he looked at the filter half-life, he found that it was much better with citrate as compared to heparin, and the RBC requirement was only 0.17 with citrate versus 0.36. It was double the amount of red cell requirements for heparin as compared with citrate. So now you got two things here. You've got citrate, you've got heparin. How do you choose? I think the first thing is local familiarity with the protocol. We have shown that citrate looks to be better. So the question is, why has citrate not become the standard of care? In the UK, most of the units are still using heparin. And I think the answer is it's our perception as physicians and nursing staff that the use of citrate is complex, it's requiring a lot of monitoring. You might end into a lot of electrolyte disturbances, and there's a huge training resource and the cost. Therefore, considering this, in the UK at the moment, barring 1 or 2 units, every other unit is using heparin as the first anticoagulant of choice. Now, if you have got a contraindication to the use of heparin and you've got unfamiliarity with the use of citrate, what do you do? And here is where we go back to the basics, where we said platelets play a very important role. And if we can get an antiplatelet agent, which we have got prostacyclin as, it's an antiplatelet agent, its synthetic derivative is epoprostenol, and it acts on the very first step of hemostasis. It inhibits platelet aggregation and adhesion, and also has got a heparin sparing effect. When I say heparin sparing effect, I mean if you were able to achieve an ACT of say 120 with 20 units per kilo per hour, you add in prostacyclin, you will see that your ACT jumps up to 180, and your filter life, which was 12 hours, jumps up to 36. So it has got not only an antiplatelet effect, it has got a heparin sparing effect as well. I think there's some problem with the slide. Yeah, so this is just to show how prostacyclin acts. You can see here, this was pre-prostacyclin. This is the TEG or the rotum. You can see a maximum amplitude being more, which means the clot strength is higher. And after we started prostacyclin, the clot strength becomes lesser. So it weakens the clot as well. And if you look at the kinetics, it has got 2 major effects called vasodilatory effects. People are really scared that if you start prostacyclin and patients will end up with hypotension, but that effect comes only at 20 nanogram per kilo per minute. The major antiplatelet effect is seen between 2 to 8 nanogram per kilo per minute. It lasts for about 2 hours, whereas the vasodilatory effect lasts for about 40 to 50 seconds. The major side effect, I would say, is the limited clinical experience which people have. The best thing which can happen with the use of prostacyclin is that there is no complex monitoring. We go by clinical things, we look at bleeding, we look at hypotension, and if we are worried, we use a TEG or a rotum just to see which component of the clotting is affected. As I said, the biggest problem is that there is no data on the dose, the route, the indications, and most work carried out is in patients where there is contraindication to heparin and citrate. If you look at these various studies which are put on paper, these are the use of prostacyclin as an anticoagulant. There are only 2 pediatric studies. One was in 1988, and second was from our group in King's in 2015. As we speak, data is being collected from our center, and I'm going to present a part of it. This is our prostacyclin protocol, which is easily available on your PCRRT.com, where we say that you start at 4 nanogram per kilo per minute. Monitor your circuit life. If your circuit life is less than 48 hours, you go up in steps and you reach 8 nanograms per kilo per minute. And this is an in-depth review, prostacyclin as an anticoagulant, which was published, I think, a couple of years back in Blood Purification. And this is the data which I'm going to present. It's a 7-year data. We are collecting more data. As I said, as we speak, 2 of our research fellows are collecting the data in my office. This is all children on CRRT, about 119 of them were studied. We looked at the efficacy of prostacyclin. We looked at the safety of prostacyclin. When I said efficacy, we looked at the filter life and mortality. When I talk of safety, we looked at the bleeding episodes during CVVH. We looked at the hypotension, i.e. requirement for fluids and vasopressors, and the units of platelet and red blood cell consumed. You can see here that the total hours of treatment were about 18,000, of which 11,000 hours of CRRT were with epoprostenol and about 5,000 hours were using heparin. And if you look at the results, very clearly, prostacyclin has got a better filter life in both liver and our non-liver failure patients. So in our unit, whether you have a liver disease or a non-liver disease, we use prostacyclin as an anticoagulant. If you look at the safety profile here, you will see that the hypotensive episodes are comparable between prostacyclin and heparin. And if you look at the bleeding episodes, again, 6.7% with prostacyclin versus almost 35% with heparin. So it's not only efficacious, it is very safe to use as well. And if I have to conclude what I've just said, I think as a sole anti-hemostatic agent, it increases our filter life, it decreases the bleeding risk without increasing platelet consumption, hypertension, or mortality. But of course, cost effectiveness is something we need to lay our eyes on. It is costly, but if your filters are clotting more frequently with heparin, the filters are more costlier than the cost of prostacyclin. And if you run into trouble, your filters are clotting more frequently because now you've got less antithrombin 3. What we use a three-way tap here. We use heparin at a dose of 10 units per kilo per hour, and then you use prostacyclin at 4 nanogram per kilo per minute. And we have almost always found that this filter clotting stops, the ACT goes up, and we're able to achieve a decent filter life. So after talking this, can I say prostacyclin is safe and effective? Yes, having years of experience with using prostacyclin, it acts regionally. It does not have systemic effects on the patient's circulation. It can be used in patients with coagulopathy. It prolongs the filter life. And very importantly, it suits my patient population, i.e. the liver patients whose platelets are low, whose INRs are high. And the protocol is very easy to use and follow, and they have got minimal side effects. So in summary, I can say heparin and citrate are the most commonly used methods. Heparin has got a bleeding risk. Citrate has got metabolic problems. Evidence does favor the use of citrate, but prostacyclin, I think, can be a good alternative if you run into trouble. It's not a difficult protocol to use, but very, very, very importantly, don't change the protocol just because, for example, you're on this webinar, you've heard me speak on prostacyclin, go back and change your protocol. It doesn't work like that. Make sure that your nursing staff, make sure the people who run the shop floor are well trained. They should know they're using a particular drug, what are the effects, what are the side effects, what to do if the side effects develop of a particular thing. Very quickly going on to anticoagulation special circumstances, especially, as I said, patients with COVID. They are in a hypercoagulable state. You see that you've got endothelial cell dysfunction, lots and lots of inflammation with TNFs and with interleukins, and you end up in a state of thromboinflammation, hypercoagulability. And this is what it does. It causes arterial thrombus, it causes venous thrombus, and very importantly, it causes localized intravascular. What we saw at King's, that filters were really clotting. We exhausted our machines, we exhausted our consumables, which included anticoagulants and the filters as well. And this is just a summary of what could be potentially done in the pandemic situation when there is a shortage, and you can use things systemically or regionally. Most of the patients with COVID are on systemic heparin because they have got thrombic phenomenon. If they are not, you use a bolus of 20 units per kilo of heparin. Start heparin the same way as we use for a non-COVID patient, and maintain your ACTs between 180 to 220. If you're using citrate, aim for a slightly lower ionized calcium in the range of 0.2 rather than 0.3 to 0.4. You can combine systemic heparin and you can combine regional citrate in the same way. And if you're running short of infusion pumps, which we did, you don't have infusion pumps to give citrate or heparin, you can use low molecular weight heparins, and you can combine low molecular weight heparin with citrate as well. Remember, this is a pandemic. These are unprecedented situations. You will have to do certain things which you are not used to doing. This is an in-depth review which we have written from the critical care nephrology section of the European Society, Mehak, Zach Ritchie, and myself on acute kidney injury and special considerations. What do you do during renal replacement therapy in COVID? And this paper has just been released 2 days back on how do you care for patients who are critically sick with COVID. And this has got a whole section on AKI and CRRT. Now, coming very quickly to anticoagulation, it's a myth that patients with liver disease have got a very high INR, the circuits will not clot. And this is a work with from one of our colleagues at King's, where he has shown that not only are the anticoagulant factors decreased, you have got the procoagulant factors decreased as well. So you've got a balanced coagulation. And if you look at the endogenous thrombin generation potential, you have got patients with acute liver failure who've got a high endogenous thrombin generation potential as compared to controls, which means these patients are very prothrombotic. So these circuits require anticoagulation, I think, more than a patient without liver disease. And we do not use no anticoagulation. We can use low-dose heparin, but as I said, our unit is an exclusive prostacyclin using unit, 4 to 8 units per kilo per minute, 4 to 8 nanograms per kilo per minute, and you can combine it with low dose heparin. So what do you do on a ward round? Ask the nursing staff, any problem with circuit or filter? How many circuits or filters have you changed? What was your transmembrane pressures? What was your access pressures? And have a very close look if things are clotting very frequently. Look at the size of the catheter. Is there leakage? Is there bending? Look at your anticoagulation, the dose, the ACT, and bleeding. So basically attention to detail, and attention to detail, very important, especially I think as physicians, we don't do that very often. In conclusion, I would say there's no perfect choice of anticoagulation. Think of the patient's disease, think of access, think of blood product use, and please do not change the protocol just because you have heard something somewhere. You need to make sure that the whole team is on board with this. This is the book which Stuart Goldston from Cincinnati and I had written, and there's an exclusive chapter on anticoagulation and various protocols, and you can go and have a look at this chapter. And I think that is where I end. Thank you.
Uma, madam?
Yeah, thank you, Akash. It was an excellent, comprehensive talk, and for the insights you gave us during the COVID epidemic, which, you know, everybody is very keen to know as much as they can. With this, I think we can proceed to the next talk by Dr. Prasad Devarajan. I think Prasad does not need an introduction to anybody working in nephrology, because he's been a pioneer in the biomarkers area, and we always read his work and his references when we read about biomarkers. He's professor and director of nephrology and hypertension, Cincinnati Children's Hospital and Medical Center, University of Cincinnati. And he has his specific interest in acute kidney injury, biomarkers, and kidney stones. And as I said earlier, has done pioneering work in biomarkers. He has a number of awards and honors. He's amongst the top 1% of the most cited publications in medicine. He has an annual Academic Excellence Award, a Jeff Gray Translating Mechanisms to Management in AKI Award. He's elected to Association of American Physicians, and he's listed in the Thomson Reuters World's Most Influential Scientific Minds. Welcome, Prasad. It's a pleasure to have you. You can start your lecture.
Thank you, madam. Can you hear me?
Yeah, we can, sir.
Okay, great. So thanks to the organizers for inviting me, and it's a distinct pleasure to be on the same platform as Uma and Akash, from whom I have learned a whole lot, and I'm sure all of you learned a lot today. So my talk is on biomarkers of AKI, and the main objectives are to understand the need for better biomarkers of AKI, and then to go to the current clinical status of novel biomarkers. So why do we need biomarkers in AKI? Everybody here knows that AKI incidence is high. It's rising globally, but still lacks awareness. But it has serious short-term complications, including death, and serious long-term complications, including CKD and hypertension. And the diagnosis and treatment of AKI is very, very delayed. And that's because we're still using serum creatinine mostly. It is the current gold standard, but we all know that even normal serum creatinine can vary widely with age, gender, diet, muscle mass, metabolism, medications, hydration status. And in AKI, serum creatinine can take several days to reach a new steady state to reflect the true underlying low GFR, and we all know that. And also, more than 50% of kidney function can be lost before the serum creatinine even begins to rise. And the best example of this is a living donor kidney. The living donor who donates one of his or her kidneys, that person has lost 50% kidney function. Serum creatinine stays normal for years, if not decades. But we do need to urgently early diagnose AKI because early forms are often reversible. And there's a direct correlation between the duration of AKI and mortality. But early diagnosis, we are convinced, will enable timely institution of effective treatment. So these are really exciting times for biomarker discovery, not just in AKI, but in every field of medicine. We have unbiased gene analysis for changes in kidney gene expression that we can follow. There are more than 150 publications in AKI alone. And there's proteomics, which we can use to detect novel biomarker proteins in the blood or urine. And again, so far, just in AKI, there are more than 30 publications. So we put all of this together about 4 or 5 years ago and published the fact that the most commonly found upregulated gene and protein in AKI is this gene and protein called NGAL. And that is by far the most widely studied AKI biomarker. More than 2,000 publications to date now. So I'm not going to go through all of them. And yes, there are other biomarkers that are out there, but in the short period of time I have today, I'm going to focus on NGAL. So what is NGAL? So NGAL is neutrophil gelatinase associated lipocalin. First discovered as a small 25 kD neutrophil secondary granule protein. So first described in neutrophils, but very soon we knew that small amounts are also produced in epithelial cells that are exposed to the outside, the lungs, the colon, and the kidney tubules. And in those regions, the role of NGAL is it's bacteriostatic. It prevents bacterial infections from affecting the organism. A couple of basic science slides, if you will bear with me. So this is an animal model, a mouse ischemia reperfusion model, where we do 30 minutes of ischemia and allow reperfusion, and the serum creatinine does not go up for at least 24 hours. In that same model, if you take a little piece of the kidney out at 3 hours, and you can see that on the slide there, stain it with NGAL, you can see the majority of tubules are lighting up. And lower down on the lower left-hand corner is a high magnification of two tubules. And what you can see is there's a lot of NGAL in the tubule cells, but also in the tubular lumen. And then we confirm that with another stain, which is shown in the lower right panel. Right in the tubule, there is a lot of NGAL. And that gave us the idea that this could be a non-invasive marker, which is also detectable in the urine. And sure enough, that was absolutely true in that animal model. Within 2 hours, the first drop of urine that came out of that animal was very positive for NGAL, as shown in the red triangle rectangle. Remember, the serum creatinine did not go up for 24 hours, but yet within 2 hours, we saw a lot of NGAL in the urine in this very reliable AKI model. We then created ELISAs to test it in human blood and urine, and we partnered with industry to take those ELISAs and put them onto standard clinical laboratory platforms. These are machines that are available in all your hospital laboratories. We then noticed that there has been an explosion of NGAL studies. mostly in the setting of cardiac surgery, critical illness, and nephrotoxins. And in each of these, what we saw was that you can use NGAL for AKI prediction, for differential diagnosis, and for AKI prognosis. I'm going to show you a few papers that substantiate these statements. So we'll start with cardiac surgery. This is a paper we published in The Lancet, 71 children undergoing cardiopulmonary bypass, where we measured urine and blood NGAL before and serially after surgery. And we defined AKI using the standard KDIGO definition, 50% increase in serum creatinine from baseline. And in our patient population, the increase in serum creatinine did not occur until 1 to 3 days after the surgery, very similar to that animal model I showed you. But this is what we saw for urine NGAL. In blue, you're looking at patients who had urine NGAL who also had an increase in serum creatinine 1 to 3 days later. And you can see that within 2 hours of starting the operation, within 2 hours of starting cardiopulmonary bypass, those children that were destined to have an increase in serum creatinine showed a massive increase in urine NGAL. And that increase stayed for the entire 5 days of this study. So very convincingly, patients with subsequent AKI developed a very early increase in urine NGAL. And then we did what is called as a receiver operating characteristic curve, which is a way of determining the diagnostic accuracy of the biomarker. It's basically plotting sensitivity versus 1 minus specificity. And if the area under the curve is 0.75, that indicates a good biomarker. And if the area under the curve is 0.9, that indicates an excellent biomarker. So in our hands, what we saw for the area under the curve for urine NGAL at 2 hours was an area under the curve of 0.99, which is absolutely fantastic. And so the translation of this finding is that you have a patient undergoing cardiac surgery. Within 2 hours, if you get a drop of urine and check this biomarker, you can be 99% accurate who is going to develop an increase in serum creatinine 1 to 3 days later. So really powerful tool in terms of planning for the patient. That was the first study. And then when we did a meta-analysis back in 2014, already there were 30 publications that showed exactly the same thing. Thousands of patients, lots of AKI events. And as you can see, the area under the curve remained very high in the very good to excellent range, 0.82 to 0.82. So at least in cardiac surgery, this biomarker stood the test of time. What about critical illness? So in this study, in the emergency room, we took 635 patients who were admitted from the emergency room to the hospital. And these patients were diarrhea, dehydration, pneumonia, sepsis, all comers to the emergency room. And we measured the urine NGAL before they were admitted to the hospital. And then we followed them in the hospital and determined who got AKI, which needed 2 to 3 days for the 50% increase in serum creatinine to be detected. And so we divided those 635 patients into 4 buckets. There were patients with normal kidney function who had very low levels of NGAL at admission. There were also patients with chronic kidney disease and pre-renal azotemia, meaning patients who had increase in creatinine, which got better in about a day in the hospital. And all of those patients had low levels of urine NGAL. But look at the acute kidney injury, the box on the left-hand side. All of those patients had a tremendous increase in urine NGAL. And then when we did the AUC, it came out to 0.95. So again, the translation of this finding is that if a patient with a critical illness is being admitted from the emergency room to your ward, be it the ICU or the regular floor, if you get a urine sample at admission, you can be 95% sure who is going to get sustained AKI over the next 3 to 5 days. After that, there were at least 25 additional papers looking at both urine and plasma NGAL. And as you can see, the area under the curve remained very high, 0.8. So again, even in critical illness in multiple people's hands all over the world, these large studies with many thousands of patients the admission NGAL was able to predict AKI, which occurred with an increase in serum creatinine 1 to 3 days later. What about contrast agents as an example of a nephrotoxin? So we looked at 91 children who were receiving contrast. These were all cardiac patients, so they were high-risk patients with cardiac dysfunction, and they received a contrast for studies of their heart. We measured urine and blood NGAL before and serially after the contrast, and we defined AKI the same way, 50% increase in serum creatinine. And in our patient population, that took at least 24 hours for us to be able to see the KDIGO AKI classification diagnosis. But look what happened. On the left, we're showing plasma NGAL, and on the right, we're showing urine NGAL. And in both of those cases, the patients who did not get an increase in serum creatinine had very low levels of plasma and urine NGALs. That's the black line. The blue line shows patients who did develop an increase in serum creatinine 24 hours later. You can see within 2 hours, the NGAL in both the blood and the urine goes up dramatically, and it stays up at 6 hours. And then the area under the curve there is, again, outstanding, 0.91 to 0.92 for predicting AKI. So high-risk patients who get contrast, if you get a blood or urine NGAL, you can be 90% sure who is going to get an increase in serum creatinine the next day. So this has become very useful for us in terms of planning follow-up of patients who get contrast. And again, 15 additional studies were already published by 2014, all of which showed that the area under the curve was in the 0.91 to 0.94 range. So multiple confirmations of what we initially found in children was true both in adults and children in multiple other studies. What about differential diagnosis? What we're talking about here is another study we did from 3 separate large emergency departments, more than 1,600 patients in whom we measured NGAL prior to admission, and we tried to separate out intrinsic true AKI, which we defined as a 50% increase in serum creatinine sustained for at least 3 days, so true intrinsic AKI, versus pre-renal AKI, which was an increase in serum creatinine, which was reversed with fluids within 3 days. Is there a way to use a biomarker like urine NGAL right at the time of admission to differentiate between these groups of patients? And the answer, at least in this paper, was yes. So you can see that the patients with intrinsic AKI had a dramatic increase in urine NGAL at the time of admission, whereas the diagnosis using creatinine took us 3 days. And you can see that the other buckets, chronic kidney disease and pre-renal AKI, had lower levels of NGAL at admission. And in blue dashes there, I have put a line at which corresponds to 150 nanograms per ml. Remember that number 150, we'll come back to that later. I show that here because that completely divided patients who were destined for intrinsic AKI. You can see the 3 asterisks there, from all the other types of patients. So remember 150 nanograms per ml. Critical illness, multiple other papers after we published ours, all of which showed the same thing, area under the curve of 0.88. What about prognosis? How can we use biomarkers to determine who is going to be the sickest during that hospitalization? Who is going to need dialysis? Who is going to die? And the answer to all that is yes. This is a meta-analysis of all studies that looked at early NGAL measurements as soon as the patient was admitted to the ICU and asked the question, can that measurement predict who is going to need dialysis at any time during that ICU stay? It could be 3 days, it could be 5 days, it could be 4 weeks. And the answer, the bottom line, if you look at total renal replacement therapy prediction, area under the curve of 0.8, which again, think about it. What that means is that as soon as a patient is admitted to the ICU, 1 drop of urine or blood, measure this biomarker, and you can be 80% sure who is going to need dialysis during that hospitalization. And these findings have now been confirmed in a much larger multi-center study, and that paper is in press. So it'll further confirm this finding. It's not the perfect biomarker. Like every biomarker in medicine, it has some confounding issues. UTI is one. NGAL can go up in patients with UTI. I showed you pre-renal AKI. NGAL can go up at least a little bit, and chronic kidney disease, it can go up a little bit. So we did this very large study looking at all of these confounding variables in children. And what you can see is that patients, control patients, totally normal children, had very low levels of NGAL, less than 50. And I have that line at 150, which again shows that patients with UTI, either cystitis or pyelonephritis, had an increase in NGAL compared to control, yes. And in fact, some people are using NGAL for early diagnosis of UTI while we're waiting for the culture results to come back, but that's a different story. You can see that patients with pre-renal AKI as well as chronic kidney disease also had some increase in NGAL compared to controls, but you can see the dramatic increase in NGAL in the patients with true intrinsic AKI. That's 331 patients, all of whom had levels well above that 150 cutoff. So I'm showing you that 150 cutoff again. And since then, there have been literally 2,000 papers on NGAL. And these are 5 meta-analyses of all these papers that have been published. Each one of these papers has many, many thousands of patients that they have looked at. And if you do a meta-analysis of all these studies, what does it show? Oops. It shows that the diagnostic accuracy for early AKI detection remains high, even after studying this marker for now more than 15 years. The cutoff of less than 50 effectively rules out AKI. The negative predictive value is almost 100%. So no matter what the serum creatinine is, no matter what the BUN is, if the NGAL level is below 50, that patient does not have true intrinsic AKI. So it's a very powerful rule out strategy. And then I told you the 150 number is important because a cutoff of greater than 150 strongly predicts AKI. Even if the patient looks normal right now from the kidney standpoint, even if the serum creatinine is normal, patient is not fluid overloaded, potassium is normal, the current NGAL level of 150 tells us that that patient is probably destined for AKI in the next few days. Excuse me. Let me now shift to the current clinical status of NGAL. How are we using NGAL? So our approach in our hospital is, first of all, you only measure if AKI is clinically suspected. We don't measure it in all patients. But if there's a clinical suspicion of AKI, this is a very, very powerful marker, because if the NGAL level is less than 50, like I said, that rules out AKI. And we would repeat those measures only if clinically indicated. A good example of this would be a patient who's dehydrated, gastroenteritis, whatever, gets admitted to the hospital, serum creatinine is elevated, but if the urine NGAL is less than 50, I know that this patient does not have intrinsic AKI, and all we need to do is give IV fluids and he or she should be okay. But if we admit that patient to the hospital and the next day the patient gets a nephrotoxic medication or a contrast CT, then we would repeat the measurements. Otherwise, no AKI. This 50 to 150 range is a gray zone. And again, we would repeat those measures and do serial measures such that, for example, if today the NGAL is 80, I don't know what to do with it. But tomorrow, if the NGAL is 140, well, that is a big increase. So serial measurements are important when we see NGAL in the gray zone. Now, if it's in the 150 to 300 range, we are very confident that these patients have high risk for structural, intrinsic, non-pre-renal AKI. And in these patients, we will obtain daily NGALs. We will carefully monitor the fluids, electrolytes, and kidney function. We will avoid nephrotoxins. We will assiduously avoid hypotension, maintain normal blood pressure. You heard from the previous 2 speakers how important that is. And we would consider many of the other preventative measures that are being tested clinically today. What if it's above 300, especially if it's above 500? Those patients are at extremely high risk for severe structural AKI. a value of greater than 500 very strongly suggests that the patient is going to go for dialysis. So these patients, we would obtain daily NGALs, would keep them in the ICU setting, monitor them very carefully, again, maintain BP, stop nephrotoxins, and we would consider early dialysis, depending on the clinical situation. But if a patient has an NGAL of more than 500, even if they don't satisfy all the traditional indications for starting dialysis, this is the kind of patient that we would, in collaboration with our ICUs, consider early RRT. So let me close by telling you three very recent patient stories. This is cardiac surgery. This 14-year-old boy had critical aortic stenosis. He underwent surgical repair with a long cardiopulmonary bypass time of 2 hours. And 3 days later, he developed oliguria, edema, increase in serum creatinine. Everything looks like clinical AKI. Well, it was 3 days later, but all of you know that right from the beginning, he had multiple risk factors for AKI. He had critical aortic stenosis, so he came in with low renal perfusion. He underwent cardiopulmonary bypass, which is a risk factor, especially when the time is prolonged to more than 60 minutes. So he had 120 minutes. So he has all the risk factors for multiple risk factors. So we monitored him with NGALs. His preoperative urine NGAL was 40. What that told us is that it's in the normal range. He did not have AKI going into surgery. So despite his critical aortic stenosis, his kidney function was normal with respect to kidney damage. But then after surgical repair, within 4 hours, we were able to obtain a postoperative urine NGAL, and that was 195. So we had a baseline of 40. It had gone up within 4 hours to 195. That was worrisome to us. What that meant is that we can predict structural AKI. Even though at this time his creatinine was normal, we predicted structural AKI, and this is a patient that we monitored very carefully in terms of electrolytes and NGAL. We stopped all the nephrotoxins he was getting, we maintained normal BP, and we started thinking about other preventive measures. This is all within 4 hours of starting the cardiopulmonary bypass. And then, yes, 3 days later, we were right. He developed clinical AKI, increase in creatinine, oliguria, edema. At this point, we were seriously considering CRRT. The ICU called us and said, let's start CRRT. And we did a urine NGAL, and it was 80. So what that told us is that he is recovering from AKI. So look at the delay. Look at the delay. Clinically, he looked like he was getting into worse AKI, but his kidney structural injury was getting better. His urine NGAL had normalized. So he suggested that he was recovering. So we actually held off CRRT. And yes, over the next 2 days, he became polyuric and his edema resolved and his serum creatinine normalized. So in this case, we were able to use NGAL first to predict structural AKI and put in place preventive measures. And then 3 days later, even though clinically we were asked to consider CRRT, we held off on dialysis and the patient did recover. So it can be used not only as a predictive marker of AKI, it can also be used as a recovery marker. And we use this commonly in patients who are undergoing dialysis to tell us who is recovering and who can be taken off dialysis. Here's another case, sepsis. 18-year-old pre-medical student, he had appendicitis and perforation. He underwent emergent abdominal surgery and he did okay, but 3 days later he developed sepsis. And we had to give him very broad spectrum antibiotics. And 6 days later, he developed clinical AKI, decreased urine output, increase in serum creatinine. Again, multiple risk factors for AKI. He had abdominal perforation. He underwent abdominal surgery. He developed sepsis. We gave him nephrotoxic antibiotics. Everybody here knows that this is a setup for AKI. So we measured NGALs. So initially, after abdominal surgery, he did well and his creatinine was normal, but his NGAL was already in the 200 to 300 range. Again, telling us that he had structural AKI, even though he did not have an increase in serum creatinine. So we stopped nephrotoxins, controlled blood pressure, gave him other measures, but it didn't work in his case because he developed sepsis on top of everything. And we gave him broad spectrum antibiotics. 3 days later, creatinine is still normal, but now the urine NGAL is almost 4,000. And we see these values of 4,000, 10,000, 15,000 in patients with sepsis. Now, what that told us is that he's got severe structural AKI. Like I said, this is a patient who is destined for CRRT at this point, even though the creatinine is normal. So we changed all these antibiotics, we did tight fluid control, and we prepared the patient and the family and the ICU to start CRRT. And yes, 6 days later, he developed clinical AKI. And then his creatinine was slightly increased, 2.6. Remember, he's 18 years old, so 2.6 is not that bad, not an indication to start dialysis. But his NGAL was now 6,000. So for that patient, that was totally diagnostic for severe AKI. And we indeed started CRRT, even though the patient was not very fluid overloaded, even though the patient's creatinine was normal or not bad enough to start dialysis. And even though his potassium was normal, we started CRRT. This is the last case, acute illness. This is a true story. This is the kidney pathologist from a famous US hospital who was on vacation with his wife in Italy, having a great time, but he got sick there. So he goes to the emergency room there with vomiting and diarrhea. They check his serum creatinine, it's 2.5. He calls his famous nephrologist in his famous US hospital, and that nephrologist says, you better come back home right away. You probably have bad interstitial nephritis. I'm going to do a kidney biopsy, and we need to prepare for dialysis. But a kindly emergency room doctor in Italy walks in. By the way, this marker is widely available in Italy, and says the urine NGAL is 42. What do we do now? Do we send him back to US for a biopsy and dialysis? No, absolutely not, because this is normal urine NGAL. It predicts pre-renal azotemia. So the ER doctor in Italy just gave him some IV fluids, sent him back to his hotel, said relax for a day, brought him back the next day. His creatinine was normal. He fully recovered. He happily completed his vacation and saved his marriage. And this doctor sent me a very nice email saying, thank you for saving my marriage. Last slide. What is next for AKI biomarkers? I've just shown you that you can predict AKI, you can predict its severity, you can predict who's going to need dialysis, and you can predict recovery from AKI. Today, what we're using this for very commonly is in interventional studies. So if you have a patient at risk for AKI, we measure NGAL in all these patients. And if you look at the upper limb of this slide, if the NGAL is normal, then we just give that patient normal standard of care, no additional treatment. And what we see is that in those patients, the NGAL remains normal and they don't get AKI. If we measure the NGAL in these patients at risk and it's high, irrespective of the creatinine, I'm not talking about BUN creatinine, just an NGAL measure. If the NGAL measurement is high in a patient at clinical risk for AKI, then we randomize them. We randomize them to standard of care or give them a placebo, or we give them specific treatments. It could be early CRRT, it could be an early Lasix challenge, or it could be any of the experimental medications that are being tried. And what we have consistently seen is that the patients with a high NGAL who are not treated because their creatinine is still normal, they end up getting continuously high NGAL and they get more AKI. Whereas the ones with high NGAL who are treated successfully, the response to therapy or the outcome is a reduction in NGAL and subsequently a reduction in serum creatinine and less AKI. So NGAL can be used as a tool to cherry pick your patient for treatments, and it can be used to monitor the response to therapy. And with that, thank you for your attention. I'm happy to take questions.
Thank you, Prasad, for your excellent talk and giving us a good insight over the clinical application of NGAL as it stands today. I'm sure everybody learned a lot and would have a lot of questions. So I think we'll... go through the questions.
So one of the questions there is, can NGAL levels differentiate between pre and intrinsic renal failure? That is higher NGAL, more chances of intrinsic. Absolutely, yes. And this is one of the most important indications currently of using NGAL, even in a patient with increased serum creatinine. If the NGAL level is normal, that patient most likely has pre-renal. And if the NGAL level is high, the patient has true intrinsic structural injury, even if the creatinine is normal. Next question is role of urine NGAL in post-obstructive AKI. Excellent question. It is currently being widely studied. And what we know is that in patients with obstruction, even after repair of the obstruction and even after a diuretic response, if the NGAL level remains high, that indicates structural damage to the kidney. And in fact, in all of our patients with posterior urethral valves or with other forms of obstruction, we monitor the urine NGAL levels as an indicator of how good the kidney function is, along with serum creatinine. How about the NGAL cost is the next question. Yeah, great question. So the actual NGAL test can be done for about $10, but that doesn't include, the tech time and the machine time. So typically for about $20, we can do an NGAL test. Yes, that's much more expensive than a serum creatinine, but we have done the cost analysis. Many other groups have done the cost analysis and have clearly shown that this cost is just a fraction of what the cost is in terms of the clinical care of these patients. So the overwhelming answer to that question is yes, it is more expensive than serum creatinine, and it is being offered at a much lower cost. Those costs I quoted are in the US. It is being offered at much lower cost in countries such as China, Korea, and even in India for that matter. Any study regarding the use of NGAL in early and delayed post-renal transplants? Yes, I did not have the time to go into that. It is an excellent marker of delayed graft function. So patients who go for transplant, as soon as they come out, remember they have huge amounts of fluids. They are usually in a diuretic phase, and it's really difficult to use creatinine in those patients. But NGAL has been extremely effective. So a level, again, greater than 300 in patients post-transplant is strongly suggestive of someone who's going to get delayed graft function. It is not such a good marker for rejection, but it's a good marker for delayed graft function.
Thank you, Prasad, for answering all the questions. I had one query. Yeah. What is the rationale of starting early CRRT when you have NGAL high? What is CRRT removing that improves the function of the kidney?
Yeah, again, great question. So CRRT is not, first we have to take into account the clinical situation. Typically, these patients are either having multi-organ failure or having sepsis. They are beginning to show evidence of AKI. The creatinine is beginning to go up, they're beginning to get fluid overloaded, but we know based on a very high NGAL, if that NGAL already is 500 or above, study after study after study have shown, prospective studies have shown that that patient is destined to get true AKI, is destined to get fluid overloaded, is destined to need dialysis in the next couple of days, and is destined for high mortality. By starting early CRRT, we're preventing fluid overload, we're removing bad cytokines, and we are allowing the intensive care physician full liberty to do everything else that he or she needs to do, including nutrition, blood products, antibiotics, everything else that would otherwise cause fluid overload. So we're preventing fluid overload.
Thank you. Akash, there doesn't seem to be any questions regarding anticoagulation If anybody wants to ask anything, please put it up in the question box. There's one question, I think it's addressed to my talk, regarding contraindications for PD because of abdominal surgery, any time frame? I don't think anybody has really studied this. If there is a time frame, most people would opt for another modality. But perhaps at the bedside, if you do not have any other modality and PD is only your option, I think you stand a high risk of a secondary wound breakdown if you start PD without full healing of the wound, because the volume you put in is going to kind of open out the wound and also may cause leaking. So I don't think there is till the wound does not heal fully, I don't think it's possible to do a PD successfully.
I think there's a couple more questions for me, if I may. One says, should we measure both plasma and urine NGAL or single one? Yeah, good question. So it depends on access. So if a patient is anuric, you cannot measure urine NGAL. You have to go with plasma. Critical care doctors prefer plasma to urine because they're always measuring things in the blood. Nephrologists prefer urine NGAL because the urine is a direct reflection of what is going on in the kidney. So for example, in a patient with just sepsis without AKI, you can get an increase in plasma NGAL without an increase in urine NGAL. What that means is that there is inflammation going on in the body, but it has not affected the kidney yet. We believe that urine NGAL is a little bit more specific for kidney injury, whereas plasma NGAL is a very good marker for general badness, if you will. And then the last question there is, can we do dialysis preemptively in a patient with high NGAL? Again, that depends on the clinical situation. If you have a patient with sepsis, with multi-organ failure, with an NGAL of 500 or above, to us, that is telling us that this patient is so clearly destined for fluid overload for AKI that yes, we would consider doing preemptive CRRT in these patients. Can we use renal supportive therapy in presence of high UNGAL? Yes. So you can use whatever is available to you. We prefer CRRT, especially in these patients with sepsis and multi-organ failure, because they have hypotension, and CRRT is a more kinder, gentler way of doing it. But if you don't have CRRT, yes, I think PD will work, although that has not been studied yet. Role of NGAL in neonates, a little bit more complicated. Like everything in neonates, it's a little bit more complicated because NGAL itself, even normal NGAL, changes with gestational age. So the more premature a baby is, the higher the NGAL is. And the reason for that, there's a good biological reason. NGAL is required for nephrogenesis. It's a very important protein involved in normal kidney development. So the more premature the baby is, the higher the normal NGAL is. But after birth, the role of NGAL is exactly the same as other children, which is if you see a serial increase in NGAL, that is indicative of acute kidney injury of the structural variety. There's a question for Akash. How do we diagnose heparin-induced thrombocytopenia and treat?
Hi. So heparin-induced thrombocytopenia is defined as platelets less than 50,000 after you've started heparin. And I think the treatment, of course, I think what we do in our center is we stop heparin and we substitute it with prostacyclin. We don't do anything different. And of course, the question might be, if the prostacyclin is not available, what do you do then? Then we actually stop heparin for 6 hours and then restart heparin at 50% the dose.
Thanks, Akash. Another question, the cutoff value of urine NGAL and PNGAL, are they similar or different? The meta-analyses indicate that they are similar. They may not be identical, but they're similar. That's why I gave the range. So 150 to 300 in both urine and plasma NGAL suggests structural AKI. Greater than 300 to 500, both in urine and plasma NGAL, indicative of severe AKI that is destined for dialysis. And I think I already answered the question, how does urine NGAL compare to plasma NGAL? In terms of performance, I think urine NGAL is more specific for kidney injury, whereas plasma NGAL is more sensitive for general badness, including sepsis, which then leads to AKI. Along with clinical context, will persistent elevation of NGAL above 300 be better indicator than a single value? Absolutely. Like every marker, if we see an elevated level in the clinical context, we have to repeat it to be sure. And especially if it continues to go up, if it's 300 today and 400 tomorrow, that would further push me towards considering RRT rather than a single value. Absolutely correct.
What is the status of NGAL in preterm babies?
Complicated because even normal NGAL changes with gestational age. So the more preterm a baby is, the higher the NGAL level is. So we have to take that normal higher level of NGAL in preterm babies into consideration when we're using it for AKI detection. But there are sufficient studies out there to indicate that you can use it in preterm babies as long as you do the serial measurements. So normally in a preterm baby, NGAL is high and it serially goes down until the full gestational age is achieved. That's the normal situation. But if it's not going down and if it's going up, on the other hand, that is quite indicative of AKI.
Okay. Thank you.
There is one more.
Or any other biomarker alongside NGAL?
Yes, I did not have time to discuss the one other biomarker that is well studied is the cell cycle biomarkers, which is IGF, BP7, and TIM2. They are slightly delayed compared to NGAL. So if you look at patients who develop AKI, the NGAL goes up first within 2 to 4 hours. And then the cell cycle biomarkers go up a little later, around 12 to 24 hours. The one disadvantage of the cell cycle biomarkers is that you need a special machine, a proprietary machine, and a proprietary kit to measure those biomarkers, the cell cycle biomarkers. And they are a lot more expensive than NGAL. Having said all that, yes, they're quite promising, and they're being studied alongside NGAL at this point.
Akash, there's a question for you. Are we overdiagnosing hepatic-induced thrombocytopenia for any thrombocytopenia and end up stopping heparin?
So I think it depends at what level you start your platelet count. If you start with a normal platelet count and after starting heparin you get thrombocytopenia, this is hit. And it's not, of course, there are confounding factors, like, for example, if you go into DIC and sepsis and you are on CRRT for that, of course, there are confounding factors for that. In that, you talk to your pathologist, get a blood film done, and that's how you diagnose it. But again, as I said, it depends upon your correlation between when did you start CRRT and when did the thrombocytopenia begin.
There's one more question on NGAL in unilateral renal vein thrombosis.
Yes. So any unilateral injury will result in increased NGAL production from that particular kidney. But if there's a normal kidney on the other side, the NGAL level is normal from that kidney, and so it is diluted out. So we've studied this in animals when we do unilateral ischemia, unilateral thrombosis, and if we can cannulate the ureter on that side and measure the NGAL from that kidney alone, then yes, NGAL is elevated. But if we look at the urine from the bladder, it's diluted out by the normal kidney, which normally produces a lot more urine than the abnormal kidney and will have normal NGALs in them. So the total amount of NGAL in the urine in unilateral injury tends to be normal. So it's not very useful in unilateral injuries. Good point.
I think this has been answered, urinary NGAL or serum NGAL to predict or detect early AKI.
I think so, yes. I hope I have answered it.
There's another question. Though we decide to initiate CRRT early, by the time we insert the catheter and get the machine and technician, it ends up becoming late CRRT. Any practical suggestion to overcome it? You know, I think everybody has gone through a learning curve. So if you compare the time when we first started any new technology, it takes a little time for the whole team to get together, increase their proficiency, the speed with which they can set it up. And I think with time it improves. So you need to have a kind of a protocol, a little time which is realistic in your unit to get all that. And then keep trying to shorten it. If it has taken you 3 hours today, you know, make it, try and get it by 2 hours the next time and gradually go up. So I think it's just a matter of doing it more often and getting your team together.
I'll need to apologize. I need to nip off for my ward rounds. I'm on call, sorry. But thank you so much for everyone. Thank you.
Thank you, Akash.
Thank you.
Thank you, sir.
Bye, Prasad.
Bye, Akash. Take care. The last question there is NGAL in post-transplant patients. As I indicated, NGAL post-transplant is a very good indicator of delayed graft function, but it has not panned out as a good biomarker for acute rejection.
I think we've come to the end of our questions. So if there are no more questions, I think I'd like to thank Dr. Prasad for his excellent talk and patiently answering all the questions. Thank you so much for being here today.
My honor, my
Thank you
pleasure.
so much. Thank you so much, madam. Thank you, Dr. Prasad, as well. Thank you so much, sir. It was really a brilliant discussion. Thank you so much. Bye-bye, sir. Bye, ma'am.
Bye, Kalaimani. Thank you so much for everything.
Thank you, ma'am. Bye-bye.